So today we're gonna start a very important topic, which is stroke. Let's start it. Bismillahirrahmanirrahim. Basically, when there is an occlusion of a blood supply to a specific area, means the blood supply is not to that specific area, so that area becomes ischemic, and then it suffers from stroke. A stroke can be rapid onset focal neurological deficient due to vascular lesion lasting more than 24 hours, or transient ischemic attack, which is actually focal deficient lasting for less than 24 hours. Two major culprits are diabetes and hypertension. Okay. Now, clinical features like in inspection, you will see how the patient walks. Does the patient has nasogastric tube or not? What is the posture? Either it is flexed or upper limbs or extended lower limbs, wasted or edematous on effective sides. The tone will be spastic, rigidity and clasp knife. Resistance to the movement, then sudden release. Ankles may demonstrate clonus, which is more than 4 beats, and power is reduced again. Now, this is the grading of power. If the patient has MRC grade is 0, there will be none. If grade 1, flicker, grade 2 moves with gravity neutralized, and grade 3 moves against gravity. Grade 4 has reduced power against resistance, and grade 5 is actually normal. What are the signs is usually when extensors are weaker than flexors. These both are the muscles in the upper limbs. Okay, so extensors is another is one muscle, and flexors are another muscle. So they are saying in the stroke the extensors are weaker than the flexors in the upper limbs, but vice versa in lower limbs. Coordination, it is reduced often due to weakness, but can be seen in posterior circulation. Strokes reflexes are brisk with extensors planters. Offer to walk the patient if they are able to do demonstrate the flexed posture of the upper limb or a tipping toe of the lower limb. Very important. Tipping toe. Taste sensation that this is a tricky and should be avoided if possible. Proprioceptions, it is important for rehabilitation. Okay, means very important. Proprioception is basically when the patient know of its position and movements. So it is very important for rehabilitation. Now, extra points: upper motor neuron, unilateral facial weakness that spars the frontalis because it has dual innervation, gag reflex against falling to minimize aspiration, visual freeze, and higher cortical functions are impaired, irregular pulse and blood pressure, and cardiac murmurs or carotid bruits, that is anterior circulation stroke. In anterior circulation stroke, there is basically cardiac murmurs and carotid bruits, blood pressure and irregular pulse. Okay, what you will do? Uh, Full blood count ECR for young CVA may be due to arteritis, and see the glucose for diabetes, renal function LFTs, and liver test, and then ECG for arterial fibrillation, chest X-ray for cardiomegaly or respiration, CT scan for infarct and blood territory. Consider an echocardiogram, carotid Doppler, MRI, AV dissection, or venous sinus thrombosis in young patients. Clotting seen, which is thrombophilia case. How will you manage the patient? For acute stroke, give the aspirin. For second, give aspirin plus clopidogrel or percetanin or warfarin. Clopidogrel, percetanin, and warfarin. Refer to specialist stroke unit, multidisciplinary approach, physiotherapy, occupational therapist, speech language therapy, specialist stroke rehabilitation nurse. Give also. So this is the acute stroke unit. Basically, it is the team for that. DVT prophylaxis thrombolysis if less than 3 hours from onset, and dedicated service available for chronic carotid ender and arteriotomy in patients who have made a good recovery. For example, PACS if more than 70% of stenosis of the ipsilateral internal carotid artery, or anticoagulation of the cardiac thromboembolism, addresses the cardiovascular risk factors, nursing and social care.